Assalamu alaikum wa rahmatullahi wa barakatuh. You're listening to ReviveFM. This is the Family Medicine podcast where we review pertinent articles, reform our understanding of medical information, and aim to revolutionize the practice of family medicine with our voices. Welcome to ReviveFM. This is your host, Daniel الغيثي. With each episode, we have 3 guests joining us, 1 family medicine physician and 2 family medicine residents. Dear guests, welcome to the studio. Please introduce yourselves.
السلام عليكم. معكم دكتورة أماني AlTai, consultant family medicine, John Hopkins Hospital. It's my pleasure to be with you today, and إن شاء الله نكون خفيفين عليكم ونقدم لكم كل المعلومات اللي تحتاجوها.
Assalamu alaikum, everyone. This is Maryam AlSoweilem, senior family medicine resident at Imam Abdulrahman bin Faisal University and ACFMG certified physician, and it is my absolute pleasure to be here as well.
السلام عليكم. اسمي نور BaMohammed. أنا R3 Family Medicine Resident في جون هوبكنز أرامكو HealthCare. مرة شكرا إنه دعوتوني اليوم وإن شاء الله نبدأ.
The pleasure is all ours. Okay, so I hear today we'll be talking about antenatal care and we'll be starting with a case.
Absolutely.
Yes.
اليوم معاكم we're going to talk about the antenatal care and all the complications and the common medical problem during pregnancy.
Mm-hmm.
And we'll go throughout with the pregnancy stages.
Yes, wonderful.
We'll be starting with a case?
Yes, right. Now, Noor and Maryam, Sarah, she's 27 years old lady. She's newly married, came to you to the clinic. She's trying to conceive and she would like some advice.
Okay. First and foremost, we should take a detailed history about her current medical history. Does she has any comorbidities, such as diabetes, hypertension, hypothyroidism? We shouldn't also forget if she is, in fact, has a chronic illness, what type of medication she's on. Since some type of medication is teratogenic in pregnancy, and this should be taken in consideration.
Also, we ask about past surgical history,
Right.
Especially bariatric surgery. طبعاً في البariatric surgery دائماً إحنا نقول الوحدة لا تحمل في فترة rapid weight loss عشان ما يصير في مشاكل عليها أو على البيبي، فأحسن شيء إنها تأخر الحمل 2 سنين. كمان you mentioned about the past medical history. We look about إذا هي عندها أي شيء high risk زي الإبيليبسي أو أي حاجة that interfere يعني زي ما قالت.
Right. And medication history as well, as you said, as well, very important.
We shouldn't also forget about the immunization status of the patient, since there are a number of vaccination that a patient should be vaccinated against, and it is contraindicated in pregnancy. And this is the period that we should tackle this vaccination in.
Which vaccine, Maryam?
MMR.
She should avoid?
MMR. We should be taken in the preconception period, and also varicella. And these 2 vaccination, the patient should wait at least 4 weeks before considering getting pregnant.
Okay.
Also about COVID vaccine. يعني إحنا في
COVID
pandemic.
How can we forget COVID?
2 years from our life.
Yes.
فالمفروض يعني تكون ماخذة كل الجرعات قبل الconception، بس هو يعني consider safe في البريجنانسي، بس الأفضل تاخده من قبل البريجنانسي.
Okay, fantastic. If any history of smoking?
Yes, of course.
Social and exposure history.
Brilliant.
تمام. إذا كانت هي alcoholic ولا بتستخدم شيشة ولا vape ولا أي أنواع من أنواع السموكينج، she should avoid it before she get pregnant. Also exposure يعني إذا كانت هي بتشتغل radiologist.
صح.
she should avoid
care
that.
our fellow radiologists.
Great. And we don't forget the antidepressant medication as well.
And also infectious, exposure to infectious agents such as
Exactly.
toxoplasmosis, rubella, and parvovirus.
Absolutely. Or any history of sexual transmitted disease as well.
Of course.
Maybe affect her chance of pregnancy.
Absolutely. Right. Now, coming to Sarah, she is 27 years old. She's pregnant, and this is second pregnancy for her. And she is 5 weeks by date. She said that she's 5 weeks and did pregnancy at home is positive. Now she came to you as a first visit. What are you going to advise her?
Okay, first we have to take a detailed OBGYN history, including, as you said, she has 2 children, right, Dr.?
She has 1 child.
1 child, okay. So the gravida states, the bara state, and if there is any miscarriages before. And the mode of the delivery of her previous child. Is it NVD or is it cesarean section? And if it is cesarean section, why is that? Did she had any medical or OBGYN complication during her first pregnancy, such as preeclampsia, GDM, and so on? Okay, and of course, we had to measure or ask about the first date of the last menstrual period. And from that, we can estimate the expected date of delivery using the Nigger rule, which include adding 7 days and subtracting 3 months.
Absolutely right. Okay.
في شيء كمان بضيفه اللي هو لازم نسأل الويت حق البيبي اللي فات.
Exactly. I just want to say that. Great point. Yes. Why?
عشان لو كان البيبي مرة كبير يعني ممكن هي كان عندها diabetes. Maybe she didn't follow up with the prenatal visits.
Absolutely. Exactly. And this is at the high risk for GDM, right?
Yes.
Okay. Another point, she had any surgeries before?
Yeah, we ask about the surgery and social history, of course. Like the pre-conceptual visit, we take full detailed history about everything, and also past medical history, especially if she taking like, is she a hypothyroid? She taking her medication, she compliant. Also, we must adjust the dose by increasing 30% of the dose. So we prevent اللي هو pronunciation حقي صعب. Carniticus. لا Carniticus هذا في الجاندس. الكرينيتيزم حق الهايبوثايرويد.
Which is the definition of it? What it is?
إنه hypothyroid في child.
Neonatal.
Yes.
Neonatal hypothyroid.
That cause mental challenging.
Okay.
عشان mental retardation بطلوا يستخدموها.
The important point is every family physician has to know that patient with hypothyroidism and levothyroxine should be increased by 30%.
Yes.
Yeah.
Actually
even before seeing the obstetrician.
يجي في الاختبارات.
This is a good point then.
Yes.
Okay, great. Now, what you're going to do next?
We do the labs.
Right.
Okay, so each country has its own set of labs, and per the guidelines of the Ministry of Health in our country, there are some set of labs that we should test the patient in. I'd like to subcategorize these labs into subcategories to help me memorize these which labs. So, for example, hematology-wise, we should order CBC, blood group, and RH, okay, and ferritin level. Going to the endocrine screening, we should do fasting blood sugar as well as TSH. Going to the infectious tests, it should include hepatitis C antibodies, hepatitis B surface antigen, syphilis, rubella, HIV. And we shouldn't forget about the urine analysis and urine culture as well.
طبعا أول شيء blood beta HCG.
Yes.
Noor,
do you add anything about the investigation as well?
لا خلاص هذا.
I think we forgot something which is very important in our country, especially in this eastern province, which is hematological illnesses such as sickle cell screens.
Absolutely. What about chlamydia and gonorrhea?
أيوة نسأل
We should ask.
It is yeah.
لأنه في
in
vertical
some guidelines, yes, they said yeah, we can
transmission.
do chlamydia and gonorrhea.
Mm.
Pap smear?
We should offer to the patient.
Yeah. Okay. It's not mandatory, but
Yes.
we can offer.
If she didn't do it before.
Fantastic. You're doing very well. Right. Okay. Now, she's still with you in the clinic. Are you going to examine her?
Of course, first starting with the vital signs as well as the weight and height to measure the BMI, going to general physical examination. If the patient has linea nigra, linea alba, breast examination, we shouldn't forget about also labor maneuver. And I believe that's it.
Yeah.
Yeah.
Okay. Chest and heart
Yeah,
as
yeah,
well.
and fetal heart rate, yes, as well.
If it's how many weeks?
8 weeks and above.
Absolutely. Better command to examine the chest and heart just to
Yes,
be
yeah.
in the notes to know how the situation. Again, Noor has mentioned something about the weight. If we have the basic weight.
Yes.
Before preconception, and then we can calculate the calories for her, how much she allowed to take, and
Absolutely.
then not to gain much weight, because it's a mess as well.
Yes.
In olden days, moms, they kept saying, oh, you are feeding two people,
Yeah.
2 person, right? The
And
mother
they're
and
gonna
the child.
stuff you,
and then
with the
putting in
food.
weight, putting in weight,
Yes.
putting in weight. Right. Okay. Fantastic. Okay. And then we examined her now, and you ordered the lab test for her. Advice-wise about diet, Noor, can you tell us please
Sure,
about the
I will
diet?
tell you about the diet briefly. طبعا في جدول مرة كبير حتحصلوه في الAFB، حتحصلوه في كتير كتب، بس أنا حأقول الأشياء المهمة بس. أول حاجة لازم نقول لها advise her to divide her meal in small portion عشان decrease the risk of diabetes insulin resistant. Also كمان عشان هي نفسها يخف عليها vomiting والنوزيا و control the weight. طبعا أهم حاجة يعني نقول إنه لازم هي to avoid it اللي هي الفش والرو فود، عشان الفش خاصة يعني فيها high mercury، وفي أكلة في الحجاز هي حضرمية اسمها اللخم. We should avoid.
We never heard about it before. she recently told us yesterday about this new information.
So هذا برضو هو سمك قرش مملح، فيعني she should avoid it because it's fish and it's مملح.
Oh wow.
كمان الاثنين يعني.
Yes.
بعدين قلت لنا نور ريحته كمان
ريحته سيئة.
حجيب لها النوزيا والفوميتنج يعني.
بالضبط. طبعا الرو فود ككل الستيك ودي الأشياء والكافيين تقلل منه. وطبعا الانباسترايزد ميلك. الانباسترايزد ميلك some people يعني في الريستورانت يستخدموه في الماك اند تشيز دي الأشياء، في السوفت تشيز ممكن يعمل لها ليستيريا. So she should avoid it.
Exactly.
يعني هذا the main things. دكتورة أماني, do you want me to add more about this?
The important point is the liver.
Yes, the liver. Sorry, I forgot about
That's
that.
okay.
Yeah. الليفر يعني مفيدة وفيها حديد وأشياء كثير، بس المفروض ما تكتر منها، لأنه أمهات زمان كانوا يأكلوا تقول لها كلي كبدة عشان فيها حديد وانت حامل وكذا، فما ينفع تكتر منها عشان هي high content of vitamin A. والفيتامين A يكون تترجينيك على الفيتس.
Absolutely. Okay. Maryam, now she would like goes to the pharmacy getting multiple vitamins. What you're going to advise her about this, and what are the recommendation?
Okay, regarding vitamins and supplementation, the recommended folic acid dose in normal pregnancy, not high-risk pregnancy, is 400. We can increase it up to 1,000 mcg. Going to the calcium, which is also important, 1,000 milligram. Iron, 30 milligram. And we shouldn't forget about omega-3, 650 milligram. And of course, which is endemic in our area, unfortunately, vitamin D deficiency. She should take 600 international unit of vitamin D.
Nice.
Okay, fantastic. Now, she would like to have some advice about she's traveling. Is she safe to travel? and it's going for her anniversary invitation.
So about counseling about the air travel, يعني طبعا ما في أي إشكالية إنها تسافر، بس إحنا نخاف من ال long distance travel that will cause high risk for DVT. طبعا you mentioned that anniversary, happy anniversary سارة. طبعا طبعا عشان لازم يعني some concerned about the husband and intercourse or anything, they shouldn't have any يعني issue with that. She should do regular intercourse. Some studies that say special positions, but this is يعني a myth. It's not required any change. And also يعني واحد disorder اللي should avoid intercourse اللي هو placenta previa.
Fantastic. Okay. Now women, mashallah, they're driving and she's worried worried about the seat belt. She can leave it or she has to wear it?
She should use it. Unfortunately, many physicians, especially as you said, Duktora, nowadays women drive in our country.
Yes.
يعني neglect to add this advice to the pregnant women. So pregnant women should wear seat belt to protect herself as well as her baby, but wear it as a 3-point seat belt. Don't wear some of it, the vertical line, especially behind the back.
Okay.
So
fantastic. Yeah. Sarah loves to exercise. She's asking you, has she stopped exercising or continue the exercise?
You know, she should continue the exercise, but we should give a special consideration. طبعا ما نقول لها نطي وتجنني، يعني خليكي حبة برضه.
Moderate.
طيب, we should advise about the swimming. Swimming is good for her, calming her nerves. Also good for pelvic exercise strengthening. هذا كويس عشان بعدين في الليبر. Also walking, ممكن تعمل يوغا. كمان breathing exercise في اليوغا هذا مرة كويس. في ين يوغا خاصة بالبلفيك كويسة. طيب sorry. وعندنا كمان أي شيء avoid البوكسينج، السكوبا دايفينج والأشياء الهيفي ده.
Absolutely, yes. Boxing والأشياء زي هذه. You've done very well. Just I want to add a point that her psychological, how she feels about it. Is she happy? Because some women, it's unplanned pregnancy and then they feel guilty and sometimes they feel down about it. Yeah.
So لازم psychosocial.
Yes.
Okay. إنه هل هذا البريغنانسي طوعا منك وكنتي planned ولا unplanned؟ هل هي عندها مشاكل في الويت disorder؟ لا تروح تكون بوليميا ولا تكون أنوركسيا stuff like that. Also إذا كان عندها bipolar هل هي بتاخد أدويتها؟ We should change the medication. Also depression إذا كانت تقدر تسيب الأدوية أو there is some medication. هو سؤال في الاختبار اللي هو سيترالين safe during pregnancy. Yeah. وفي السوشيال لا تدخني لا تشربي ويعني دي الأشياء.
Brilliant. Okay. Now she's asking you when she's going to have her ultrasound.
Okay. Regarding the ultrasound, we have 3 ultrasound every pregnant woman should take. The first one, which is done in the first trimester, which is just dating and confirming the pregnancy. And the most important one, which is done in the second trimester from 18 week until 28 week. But making it earlier, it's going to have much better result, which is the anomaly scan. The third one, which is in the third trimester.
Okay, brilliant.
أقول شيء بس على الفيرست ترايمستر بس درول أوت الأكتوبيك بريجنانسي والمورال بريجنانسي.
Yes.
يبان
Yeah.
فيه.
Absolutely. Right. And now when we're going to test for GDM, which week?
GDM 24 to 28.
Fantastic. Okay. And the group beta streptococcus?
35 to 37.
Brilliant, because this can be an exam point, right?
Yes.
Okay. Now, mashallah, Sarah did all her labs or investigation or the advice, you got it. Now she came back to you to the clinic, said she is 9 weeks pregnant. She had her first ultrasound with gestation sac with live baby. heavy, but she is spotting what you are going to. She's so worried.
Does she have any abdominal pain?
She no abdominal pain, but she's only spotting. But she was so tearful, and she's upset about it.
Okay, most likely this is the threatened abortion.
Yes.
But we should. You're gonna say something, Noor?
Yeah,
we should
approach her history.
Of course.
The content of the blood, is there any discharge, abdominal pain, back pain, any trauma, any يعني full history. بعدين نروح على examination. During examination, if we have bedside ultrasound, we can use it to see. طبعا في examination لازم نشوف cervical os.
Yes. If it is open or closed.
Fantastic. Okay. And what's called this one?
Threatened abortion.
Threatened abortion.
Yes.
Right. Okay. And next time she came to you as well. Now she said, Doctora, my bleeding is really getting heavy, and I saw some like a fleshy thing came out of my vagina. What do you think it could be?
This one, it might be complete or incomplete. So as Noor said, we have to do examination for the patient, check the cervical os. If it is open, this means the abortion is incomplete. If it is closed, it's complete. Of course, we should do also a bedside ultrasound.
Okay, right. But now she's having pain, severe pain, and she's seeing some blood as well. What you are going to do?
This is a triad. Abdominal pain combined by bleeding in the first trimester and history of amenorrhea since she's pregnant. So this is most likely ectopic pregnancy.
Right, okay. Now, just I'm going to share the scenario. Sarah, the same person, she had scan, showed intrauterine sac, but she came with a bleeding and pain as well. She had a miscarriage, but what type of miscarriage? We did the threatened, we did the complete, we did the incomplete.
So if it's painless and bleeding, it's maybe missed abortion, missed miscarriage.
Miscarriage if nothing's seen in the sac.
Yeah.
Okay, and we call it blighted ovum, right?
Yes.
When I was doing my
recently
my gynae work. Yes. Oh, thank you. That's really nice of you. The point which I want to mention is inevitable abortion. Which is women that come with severe pain and bleeding, but you made sure that previous scan showed gestational sac. Okay, when you put a speculum, you can see the products is hanging from the cervix, and if you pull the product, then a patient feel much better.
Yes.
Okay, just I want to mention this. Coming back to ectopic pregnancy, right? Okay, now she haven't had a scan, but she delayed period, abdominal pain, and bleeding. You said ectopic, right?
Yes.
Okay, how are we going to manage this patient?
First of all, we look at the vitals, if she is vitally stable or not vitally stable. So if she vitally stable, that we will refer her to gynecology, not family medicine.
The EMS director.
Yeah.
Oh, right, okay. But
Maryam.
Maryam, do you have any comment about referring her to emergency? If she's stable. If she's stable,
they're going to kill you.
Exactly.
Stable gynecology. Unstable, of course.
Are you going to do anything in the clinic?
Of course, we're going to do an ultrasound to determine, because the definitive diagnosis is by TV ultrasound, which is transvaginal ultrasound, to see if the pregnancy, is it an intrauterine, or in fact, in case of the ectopic, it's going to be outside the uterus.
Yes. What about serial beta-HCG?
Yes, this one, in case if it is the pregnancy is less than the discrepancy level of beta-HCG, we can't view it via TV ultrasound or abdominal ultrasound. Then we have to do serial beta-HCG to confirm, in fact, that the patient has ectopic pregnancy.
In normal pregnancy, how would the beta-HCG normal pregnancy, the beta-HCG
في الفيرست trimester will increased و doubled و triple
Yes, you're right. Yes,
tripled.
it doubled every 48 hours.
Yes.
Yeah, you're right.
بعدين يوصل لسيرج طيب وما يعني خلاص يثبت على الدان.
The most important thing is to detect normal pregnancy, that it doubles in 48 hours.
Yes.
Okay, fantastic. Just I want to add a point in the ultrasound finding with the ectopic as well, is sometimes you can find some free fluid in the peritoneum if you can't see anything. Right. I think we leave the management to the more specialized people, right? The obstetrician and the gynecologist. Now, that's fine. Now, patient, she is threatened abortion, but she is having severe vomiting. She vomits every day, 3 times. Poor lady, she can't keep anything. And what you are going to advise her and what you're going to do for her?
طبعاً.
You want to start, Noor?
Yes, sure. طبعاً إذا كان severe vomiting, we will assess the vitals. We will see if she vital is stable, any signs of dehydration, if she cannot tolerate orally, so we give her fluid.
Right.
If she can tolerate orally and she يعني نشوف كيف affecting her life, ونعطيها ممكن medication زي مريم.
Vitamin B6, pyridoxine, which is the first line of medication. If it's suitable for the patient and there is decrease in the symptoms, we can go ahead with the same management. If not, we can change to safe, pregnancy-safe antiemetics such as meclizine, ondansetron as well.
Okay, just to remember, antacid should be avoid anything with salicylate.
Yes.
Because it's teratogenic.
Yes.
And advise her a small portion of meals.
Food. Yes.
Large fluids.
Absolutely. And this is called, what is the diagnosis?
Hyperemesis
gravidarum. Brilliant. Fantastic. Okay. Now, PPI, any advice about PPI?
It's class B.
Okay.
medication, so يعني في out risk وفي benefit، بس يستحسن إنه يكون في second trimester. Try avoid it in the first trimester.
Moderate.
Yeah. Absolutely. Now, the most important thing which you can face in the primary care as well, pregnant women with dysuria.
Yes.
Also, how are you going to
history
and treat?
history and في الهيستوري لازم حق الUTI نسأل dysuria, frequency, urgency, incomplete emptying، وندخل في هذا. we must exclude في الUTI البايلونيفرايتس عشان
because this is require referral.
بالضبط. أما بعدين ندخل نشوف الإكزامينيشن. طبعا في الإكزامينيشن برضو نفحص الكوستوفرينيك أنجل. بعدين نروح على اللابس نعمل point of care dipstick to confirm if we need to send for urine analysis.
Absolutely.
حتى لو كان يعني asymptomatic we must treat it.
Okay. What is the recommended antibiotic?
Okay.
Maryam, sorry.
Okay. So
I'm looking at you.
Yeah. I was like, oh, who? So the first line medication which is recommended is ampicillin, but unfortunately, because of the increasing resistance, we can give the patient amoxicillin or amoxicillin with clavulanic acid, which is augmentin. Also, we can give nitro. But nitro isn't supposed to be taken in third trimester.
Yes. Absolutely. Yes. Great. Yes. The safest option is amoxicillin, cephalosporin.
Of course, Bactrim is contraindicated.
Yeah. Okay. Exactly. Oh, fantastic. What about if patient came to you RH negative?
So as we said, in the first antenatal visit, we were going to do the RH compatibility. If the patient is negative, we have to give her an ROGAM or NTD in the 28 weeks, as well as in the time of the delivery.
Okay, fantastic. Okay. You've done very well. I think now we came at the end of the first trimester.
Sure, that was a very nice discussion about
and complications. And we'll continue with you with the second and the third trimester.
Yes, inshallah, we'll be back soon with the second and third trimester. Don't go away just yet. Welcome to our refresh segment. This segment is a fun little break where we will present you with something different and interesting with each episode. بما أن الحلقة هذه كانت عن Antenatal Care، حبينا نقدم لكم حاجة متعلقة شوية Antenatal Care but not quite. Baby blues and postpartum depression مع ضيفتنا الجميلة. Please عرفينا بنفسك.
أهلا دكتورة، كيف حالك؟ اسمي ماجدة المسحر، أخصائي نفسي أول.
أهلا وسهلا فيكي، أتشرفنا بوجودك معنا.
والشرف أنا يسعدني.
طيب أول سؤال، إيش الفرق بين postpartum depression والبيبي بلوز؟
البوستبارتم ديبريشن والبيبي بلوز الفرق بينهم في الحدة والمدة، يعني في السيفيريتي والبيريود. الاكتئاب ما بعد الولادة يكون أكثر حدة، والبيبي بلوز أقل. ممكن نقول عنه نسميه الكآبة الطبيعية اللي تجي بعد الولادة ل80% من النساء، بينما اكتئاب ما بعد الولادة ممكن يجي 10% من النساء. فالبيبي بلوز مجرد شعور بالمزاج المتقلب، أن أنا أكون طبيعية وكويسة وعندي طفل جديد وأكيد بقوم بمسؤولياته، فجأة لا، أنا مش قادرة والموضوع صعب وأبدأ يعني ما أنام كويس. لكن خلال 3 أيام إلى أقل من أسبوعين ممكن يروح بدون أي تدخل علاجي، بعكس الاكتئاب ما بعد الولادة يطول إلى أكثر من أسبوعين ويكون سيفير. الأعراض تكون في أكثر حدة، المزاج مرة ساد، في شعور بالعجز أو عدم القدرة على القيام بمسؤوليات الطفل أو بمسؤولية الذات، في اضطراب في الأكل، اضطراب في النوم، فالسيفيريتي أكثر في مقارنة بالبيبي بلوز.
أوكي، postpartum depression إلى حد كبير يشبه major depressive disorder.
Yes, it's right. لكن ممكن الفرق أكثر شيء أنه يتعلق بالأم والطفل. الأم حتى أفكارها تتعلق أكثر شيء، هي مش قادرة تعتني بنفسها وبالطفل. في الميجر depression disorder مرة مختلف الموضوع، يتعلق بالإنسان بحد ذاته يعني.
أوكي.
أكثر.
بالنسبة لك، بما إنه postpartum depression is obviously more severe، بالنسبة لك إيش أكثر شيء مهم عن postpartum depression؟
أكثر شيء مهم أن أكثر النساء عرضة إلى اكتئاب ما بعد الولادة هم النساء اللي سبق أنهم عانوا من اضطرابات عقلية سابقا، مثل الاكتئاب، القلق، اضطراب الوسواس القهري obsessive compulsive disorder، أو اضطرابات أخرى يعني مشابهة. هذول النساء ممكن يكونوا أكثر عرضة.
أوكي. مين هذه العوامل الخطورة اللي هي الفاميلي هيستوري والبريفيوس بيرسونال هيستوري، هل في عوامل خطورة تانية، ريسك فاكتورز ثانية ممكن تخلي النساء معرضين أكثر لحصول postpartum depression؟
طبعا في فقدان الدعم العاطفي من الشريك أو الزوج أو حتى من العائلة، إذا كان ما في أحد ممكن يتحمل معها مسؤولية هذا الطفل في البدايات، أو الشريك بينها وبين مشاكل، فهي ممكن تكون أكثر عرضة لاكتئاب ما بعد الولادة. وإذا كان الطفل غير متقبل والحمل غير مخطط له، ممكن هذا الشيء بعد يصير اكتئاب ما بعد الولادة يجيهم، يعني لأن ما في استعداد سابق. وحتى ممكن النساء اللي تعرضوا إلى ولادة معقدة، الولادة اللي كان فيها كثير أشياء ميديكال مثل سحب الطفل أو الولادة القيصرية، ممكن في دراسات تقول أنه ممكن يصير عندهم اكتئاب ما بعد الولادة.
يتهيألي حتى الأمهات اللي أطفالهم يكون عندهم congenital abnormalities ممكن برضو نفس الشيء.
التشوهات الخلقية أيوة. ممكن طبعا إذا كانت هي مش متوقعة هذا الشيء، أو حتى كانت متوقعة وما تبغى تكمل وما تقدر تتحمل مسؤوليته.
أوكي. هل في social risk factors ممكن برضو تأثر على إمكانية حصول البوستبارتم ديبريشن؟
ماليا، إذا ما كان عندهم قدرات مالية لرعاية هذا الطفل، سواء الزوج أو الزوجة، ممكن يصير عندها اكتئاب ما بعد الولادة.
طيب بعض الأعراض هذه أو بعض العوامل هذه ممكن يتأثر فيها الأب زي ما تتأثر فيها الأم، فهل ممكن الأب برضو يكون عنده؟
بالضبط دكتورة. فالجانب المادي هو يتحمل الأب، وبالتالي إذا ما كان مستعد ماديا للعناية بهذا الطفل وتحمل مسؤوليته فممكن تصيب أعراض اكتئاب مع زوجته في نفس الوقت حسب الدراسات.
طيب إيش تأثير البوستبارتم ديبريشن على البيبي نفسه؟
إذا ما تم علاجه في البداية ممكن الطفل يتعرض إلى نجلكت، إهمال من الأم، عدم العناية فيه، عدم تغذيته بشكل مناسب، إهمال مثلا العناية بصحته، وممكن يوصل إلى مرحلة الموت إذا كان يعني مرة سيفير الاضطراب وما تم علاجه. على المدى البعيد تقول الدراسات أن ممكن الأطفال في مرحلة الطفولة المبكرة إلى المتأخر يصير عندهم اكتئاب، أو يصير عندهم في البداية اضطراب في النمو اللغوي، أو ممكن صعوبات في مادة الرياضيات يسموها يعني صعوبات تعليمية، أو ممكن يصير مشاكل سلوكية.
أوكي، يجي ببال الواحد دائما الشورت تيرم افكت، بس اللونج تيرم افكت صراحة
أنا بعد استغربت أن في شيء زي كذا يعني. بس هم يأكدوا أن إذا ما تم علاجه وأن استمر لفترة طويلة يعني خلال سنوات ممكن يأثر لاحقا، لأن العلاقة بين الأم والطفل أكيد كانت مضطربة. صحيح. وبالتالي بتؤدي إلى اضطرابات لاحقة.
أوكي، طب لو ممكن أطلبك take home message عن البوستبارتم ديبريشن، إيش راح تقولي للمستمعين؟
المسج راح أوصل لكم اللي يشتغلوا في عيادات طب الأسرة أن ممكن يهتموا بالنساء اللي عندهم previous history من الاضطرابات العقلية، أنهم يتابعوا هذا الشيء، هل بالفعل كانت هذه الاضطرابات موجودة قبل الحمل، على أساس أن نكمل الخطة العلاجية ونشدد على إكمال الخطة العلاجية أثناء الحمل للوقاية من الاضطراب بعد اضطراب الاكتئاب ما بعد الولادة.
أوكي، أتوقع هذه نقطة نغفل عنها كثير في الفاميلي بلانينج. شكرا جزيلا، شكرا لمشاركة معلوماتك الجميلة معنا.
أهلا،
شرفتينا بوجودك اليوم.
أنا للشرف. شكرا دكتورة.
Okay, and we're back. بما أننا تكلمنا عن preconception والfirst trimester, now we're going to be talking about the second and the third trimester. دكتورة أماني.
السلام عليكم، رجعنا لكم تاني. سارة ما شاء الله pregnant now and she reached 24 weeks. جات لي دكتورة نور في الكلينيك وعندها دكتورة مريم. أنا دائما يا مريم أبص لك وأقول وأقول نور. مش عارفة أنت يا نور ماسكة في مخي ليه؟
شو مسويت لها؟ شو مسويت عمل؟
I'm really sorry. Okay, 24 weeks with abnormal OGTT. جات لي دكتورة مريم في الكلينيك. دكتورة مريم, what are you going to advise her?
طيب, most likely the patient has GDM. First and foremost, the first line in approach is behavioral changes and lifestyle modification. We can refer the patient to a nutritionist as well and a health educator to establish a well guideline for the meals that she should take, the portions, what kind of food that she should decrease or eliminate in her diet. Of course, if that failed, the first line medication-wise is insulin. The time period that we can wait between changing from behavioral changes until medication, which is insulin, is 1 month, at least 1 month.
يعني نعطيها فرصة شهر واحد.
Yes.
Okay.
نقول لها شدي حيلك, do dieting, physical exercise.
Exactly. That's what I'm waiting for, the physical exercise.
Yes. Okay. And also continuous measurement for glucose monitoring, fasting, and postprandial.
Okay. And does she need to be referred to the educational diabetic nurse?
Yes.
Yeah. Okay. Fantastic. Right. And what about the metformin, the role of metformin?
Previously, metformin, they used to prescribe it in GDM, but according to the recent ADA guidelines and recent meta-analysis, they found that metformin actually they follow up the children of pregnant women who are on metformin. They found when they reach 9 years or 10 years old, they have increased BMI and they have obesity.
Oh, interesting.
Yeah, and some studies, in fact, they found that they have low IQ.
Yeah.
So this يعني
Scary, huh?
Yeah, make you scared to prescribe metformin.
Absolutely.
Okay.
If there's an option, then no touch metformin.
Yes. Go to insulin.
There is the option no touch of any medication,
Yes,
do physical
yes, of
exercise or diet.
Yeah, absolutely. This is the most important. If they follow this, there's no problem.
Yeah.
Right. Now, I got to try it this time, Noor. Now, Sarah, but I'm going to change the scenario a little bit.
Okay.
Now, she is 20-week pregnant and she came to you with a blood pressure 140/90.
Whoa.
Okay. And how are you going to counsel her, please?
Of course طبعا حنشوف نراقب من ال first visit البلد بريشر ونقارنه بال 20 weeks. إذا كان نفس الرتم معناته هي عندها chronic hypertension فنعطيها علاج للchronic hypertension. إذا كان she just developed it by 20 weeks معناته عندها gestational hypertension. فالgestational hypertension is not preeclampsia, it's gestational hypertension. طيب وله علاج. طبعاً أول حاجة diet وإكسرسايز وبعدين نبدأ بالميديكيشن. طبعاً contraindication الأيس والأربس ما ينفع نستخدمهم في البريجننت ليدي. اللي ينفع نستخدمه اللي هو لابيتولول، نيفاتيبين and ميثايل دبا. طيب طيب إذا هي يا دكتورة أنا أقول لك سيناريو.
قولي لي يلا يا واحدة اختبريني يا نور.
طب إذا هي يا دكتورة كانت في 20 weeks وجالها blood pressure بس عملنا لها اليورين وطلع فيه بروتين ويوريا وكان عندها headache وكان عندها nausea و vomiting, I will refer her.
Because why? ليش؟
عشان البريكلامسيا.
Yes, well done. We shouldn't forget the preeclampsia, right? Because this is an emergency, really emergency. Okay, well done يا نور.
أو في شيء كمان دكتورة حابة أضيفه. إذا كانت هي بريكلامسيا من البريجنانسي اللي فات فإحنا لازم monitor her blood pressure وكمان نعطيها aspirin.
Yes, well done. Now, good. We covered the most important thing, GDM and hypertension. I just want to please, if anyone really interested in the GDM, to do auditing, because I've noticed since I came here to المملكة العربية السعودية إنه the number of patients with GDM, they can be leading to type 2 diabetes.
Yes,
and it's very high number. But if anyone interested can do auditing, because really those women, they need to be followed up, and then we tackle them, and then not to develop type 2 diabetes. And you're going to see that on the postpartum follow-up, how we're going to follow them up.
Yes.
Please, if anyone interested, just please, if can do it.
And contact us as well.
And I'll be very helpful to help as well. Okay, now we're coming to the second most common things as well, hypothyroidism with pregnancy. تفضل يا نور. تاني عملت نفس المشكلة. عايزة أقول
hypothyroidism دكتورة إحنا ناقشناه في الانتيناتال كير وقلنا إنه نرفع الجرعة ب 30%. بس أنت قصدك على الهايبرثايروديزم.
Yes.
عشان كده مريم.
تفضل يا مريم.
So for hyperthyroidism, certain medication is contraindicated in the first trimester, and some medication are preferred to use in the first trimester. So BTU, we should use it in the first trimester, methimazole in the second trimester, and so on.
هذا ترى سؤال امتحان بروموشن. ركزوا على هذه المعلومة.
You don't want to يعني
تلخبط
نقول كذا بس يعني it is very important question.
It is because very important, but not many patients with hypothyroidism. This is كمان يعني عشان كده مهم إن الواحد يتذكر الميديكيشنز. Well done. Now, okay, Sarah, she is she's 30 week pregnant, and she came to the clinic complaining of vaginal bleeding. But she doesn't have any pain. You ask her, there is no pain. What it could be?
Placenta previa mostly likely, since there is no pain.
Absolutely. Okay. And if she hadn't have any ultrasound, if she had ultrasound, then we're going to look at
we should do an ultrasound and see the position of the placenta.
Absolutely.
Yes.
Do you do vaginal examination? No. Yes.
Even intercourse is
yes.
referred to.
You remember it?
Yeah.
Well done. Right. Okay. Same Sarah, 30 weeks pregnant. She came with a severe abdominal pain and vaginal bleeding. What it could be?
Abruptio placenta.
Abruptio placenta. And you have to remember this is the difference between abruption and placenta previa.
Abruptio, you always remember something rupturing, so of course there's going to be pain.
Painful.
Yeah.
Yes, pain and bleeding.
Yes.
I don't want to go detailed at the type of abruption, but just remember it's painful vaginal bleeding.
Yes.
Placenta previa is painless vaginal bleeding. Well done. I think now we covered the most of the common medical disorder. Yes.
في الآخر شيء لا ننسى الGPS عشان في الآخر trimester من 35.
we mentioned it previously.
عشان
because of يلا عشان يا نور انت حباها هذه المعلومة.
عشان لما كنت روتيشن في الOB كانوا يعملوا النيترو بلو هذا تيست. أيوة
لسه بيعملوه لغاية
الآن يعملوه طول النهار، حتى سويته كذا مرة، فعشان كده خلاص رسخ.
أيوة عشان طب what is the complication من ال if positive؟
شو اسمه premature rupture membrane.
Absolutely. And treated with antibiotic.
Well done. Even during delivery and
yes, to prevent the infections.
Yes.
Well done. I think now we covered the most common medical disorder during second and third trimester. Right. Okay. Now the woman has delivered normal vaginal delivery. Congratulations to her. And then now went home safely, alhamdulillah. She came for postpartum follow-up. When do you recommend postpartum follow-up? How many weeks?
4 weeks.
4 weeks?
Yes.
Okay. Right. What are you going to look at the postpartum visit?
Okay. Firstly, since I spoke about GDM,
yeah,
I'm a little partial about GDM and diabetes, as you can tell. So we should do 75 gram OGTT. At least 4 weeks to 6 week postpartum, and this should be repeated every 1 to 3 years to look for, of course, type 2 diabetes.
Yeah. Just I want to comment a little about the follow-up 3 years with a high percentage number of GDM here in Asian and all Arab countries. What about if they change it annually?
Yeah, it is 1 to 3 years.
I think here it should be yearly, I think.
لا هي حتجيكي كل 3 شهور حتقول لك أبو تحليل شامل.
ونقول لها لا تعالي بعد 6 شهور ولا تعالي بعد سنة.
خليها توسوس.
Right, okay. What about the hypertension?
Hypertension, of course, يعني postpartum we should take history, examination، نشوف علاقة المذر بالبيبي، وطبعا هذا حنناقشها في other episode على postpartum blues and depression. وطبعا لازم نقيس البادي ماس اندكس ونشوف إذا هي يعني كيف الويت بينزل معاها ولا لا، والبلاد بريشر. طبعا البلاد بريشر لازم إذا كان عندها gestational hypertension نقيسه في الفولو أب، بعدين every 2 weeks. طبعا every visit we should do it.
We should measure the blood pressure.
Yes.
Fantastic. Okay. What else you mean to counsel her about?
Breastfeeding. The use of contraceptive as well.
Okay. And do we need to check the TSH as well?
Yes.
Okay. Right. Fantastic. Okay. And as well, I can add just please, all the physicians, don't forget the postpartum depression. Just always ask 2 questions. Do you know what are the 2 questions?
The duration.
Yes.
So if it is more than 10 days, this is most likely blues. If it is, if it's less than 10 days, this is blues. If it is more, this is depression.
Okay, but what the question to
BHQ2?
BHQ9.
there's two questions you ask them for postpartum depression.
إذا هي بتبكي كل يوم.
Yes, yeah.
أيوة. والله هذا على حسب ذاكرتي يعني.
أيوة.
وإذا كيف علاقتها بالبيبي.
Or you can easily in the last few weeks have been felt down or tearful, as you said, or you have lack of interest or lack of energy. Because believe me, we do miss it. We do miss it. This is a message for the obstetrician, family physician, and gynecologist. Always inquire about the psychological issue postpartum. I think we covered most important points about postpartum follow-up.
إذا كانت ما طعمت MMR تاخده postpartum.
Well done. Vitamin D and calcium? If she's breastfeeding?
Yes.
Okay.
حتى البيبي ياخد.
Do you counsel contraception?
Yes. لأنه لازم we counsel إنه ما يكون أقل من 6 شهور للnext pregnancy، لأنه لو كان أقل من 6 شهور حيجي لها more complication ويكون خطر عليها، فلازم على الأقل أكثر من 6 شهور أو سنة يعني.
Interval between pregnancies.
Oh, very nice. That's an excellent discussion. توقع غطينا أهم النقاط the highlights of antenatal care. طيب لو دكتورة ممكن أطلبك take home message.
Yes. My message is safe, happy mother, always safer outcome. and يعني شكرا للنور ومريم.
شكرا لك دكتورة.
يعني انتوا ما قصرتوا وفيتوا وكفيتوا.
انا لكم العافية.
وشكرا يا دانيا، شكرا على مقدمتك الجميلة.
الفريق كامل.
الفريق كامل.
وشكرا لكل الناس اللي ورا السين
behind the scenes.
ألف شكر لكم. وإن شاء الله يعني كنا خفيفين عليكم.
إن شاء الله ما طولنا
وكنا خفيفين عليكم والمسج وصلت.
يعطيكم العافية. شكرا جزيلا.
ألف شكر.
If you're interested in reviewing the topics of discussion for this podcast, linked below you'll find the core scientific content summaries created by our lovely guest residents. If you would like to join us and become a guest on ReviveFM, you can fill out the application form in the description box below. This podcast is brought to you by the Saudi Society for Family and Community Medicine, as well as the Family Medicine Future Group. Continue to follow our podcast on social media through the Saudi Society for Family and Community Medicine and the FMF Twitter accounts linked below. Currently, we upload regularly on both Apple Podcasts and YouTube. This has been your host, Daniel الغيثي. Thank you very much for tuning in, and we'll hope to hear you next on Revive FM. Sky is home.